Assalamu alaikum. Good day to all of you, dear doctors. Today I am going to share a brief overview about shoulder joint, which is important for both part of MRCS examination. Actually, the shoulder joint is a shallow synovial ball and second type of joint, which is inherently unstable joint but is capable to a wide range of movement. The stability of shoulder joint is provided by muscles of rotator cuff that pass from the scapula to insert in the greater tuberosity, except subscapularis muscle, which is inserted into the lesser tuberosity. Now I'm going to share a brief idea about glenoid labrum. Here's the glenoid labrum, which is a fibrocartilaginous rim attached to the free edge of the glenoid cavity. Tendon of long head of biceps arise from within the joint from the supraglenoid tubercle and is fused at this point to the labrum. The long head of triceps attached to the infraglenoid tubercle. Here's the fibrous capsule, which is attached to the scapula external to the glenoid labrum and to the labrum itself posterior superiorly, which attaches to the humerus at the level of anatomical neck superiorly to the surgical neck inferiorly. Anteriorly, the capsule is in contact with the tendon of subscapularis. Uh, Here's the subscapularis anteriorly, uh, and superiorly with the supraspinatus tendon, and posteriorly with the tendon of infraspinatus and teres minor. All this blend with the capsule towards their insertion. Two defects in the fibrous capsule: superiorly for the tendon of biceps. Anteriorly, there is a defect beneath the subscapularis tendon. Due to subscapularis tendon, the inferior extension of the capsule is closely related to the axillary nerve at the surgical neck. Axillary nerve at the surgical neck, and this nerve is at risk in anterior-inferior dislocations. It also means that proximity-sited osteomyelitis may progress to septic arthritis. Movements of shoulder joints involves flexion, extension, abduction, adduction, and medial and lateral rotation. Flexion is produced by anterior part of deltoid, pectoralis major, and biceps and coracobrachialis. Extensions occurs due to posterior deltoid, teres major, and latissimus dorsi. Adduction occurs due to pectoralis major muscle and latissimus dorsi, teres major, and coracobrachialis. Abduction, which occurs due to mid deltoid and supraspinatus. Medial rotations occurs subscapularis by subscapularis, anterior deltoid, teres major, and latissimus dorsi. Lateral rotation is done by posterior deltoid and infraspinatus and teres minor. Now, abduction has the important topics. Abduction occurs 0 to 5 degrees of abduction is produced by the supraspinatus muscle, which is supplied by suprascapular nerve. The middle fibers of deltoid are responsible for the next 15 to 90 degrees, which is supplied by axillary nerve. Above 90 degrees or past 90 degrees, the scapula needs to be rotated to a safe abduction that is carried by the trapezius, which is supplied by accessory nerve, and serratus anterior, which is supplied by long thoracic nerve. Now here's some important anatomical relations. Anteriorly, here's the brachial plexus and axillary artery and vein. Posteriorly, suprascapular nerve and suprascapular vessels. Inferiorly, axillary nerve and circumflex humeral vessels. I think now I've got a brief idea about solar giants. Okay, thank you all of you, dear doctors.